Hi, I'm Conrad Fisher, and welcome to Dermatology. I'm an Associate Professor of Medicine, Physiology, and Pharmacology at Touro College of Medicine. We'll be covering cutaneous malignancies, atopic dermatitis, also known as eczema, psoriasis, pityriasis rosea, and seborrheic dermatitis, which in common parlance is called dandruff, and blistering diseases, which is bullous pemphigoid and pemphigus vulgaris. Cutaneous malignancies are certainly more common. They are certainly greater with pale skin and in more sun-exposed areas. The diagnosis of all cutaneous malignancies is a biopsy. There is no substitute for biopsy. There is no blood test for any of them, not for melanoma, not for squamous cell, not for basal cell, and not for Kaposi's sarcoma. The treatment for almost all of them, with the exception of Kaposi's sarcoma, is surgical removal. There's very limited chemotherapy, and it would never be a substitute for the surgical removal of the disease. And there is no truly effective chemotherapy. We use interferon for melanomas and virtually nothing for squamous cell or basal cell. For skin cancer, more sun means more cancer, period. It's carcinogenic. Biopsy is the only way to make the diagnosis, and you got to remove it. Malignant melanoma is certainly more frequent in sun-exposed areas, but it is not exclusive to those areas. It's the most extraordinary thing. Why is it that it can also grow in the areas that are under cover? Why is it that it can grow in the back of the eye or under the nail folds? Well, our most important issue for skin cancer is simply for you to be able to tell the qualities of a benign versus a malignant lesion. Melanoma is clinically defined as an asymmetrical lesion, one that has an irregular border, irregular colors, irregular diameter, and expanding evolution and changing over time. Look, ladies and gentlemen, this is step 2 exam. For dermatology, if you could basically tell what needs to be biopsied, you're good, okay? That's what you need to be able to tell. No one expects you to be able to understand complex things. You're expected at your level to be able to know basically which lesions can be left alone and which lesions have to be biopsied, and not to do a shave biopsy in a melanoma. That's it. How do we diagnose malignant melanoma? What's suspicious? Biopsy! And you got to include the entire thickness of the lesion, if at all possible, because the worst prognosis is growing lesions, but we don't just mean growing side to side. We mean growing in terms of total depth, top to bottom. And you could have something that's raised just a millimeter above the skin, but it's going deep under the skin. That's why you can't shave it. You've got to do the entire thickness. If you have a lesion that's very thin, it's not going to have metastasized. Basically, if you had a melanoma, the first question out of your mouth should be, how thick was that thing? Because honestly, if it's more than a millimeter or 2 thick, you've got a very high likelihood of it going to your local lymph nodes, and it's very bad. So benign lesions are round, whereas malignant lesions are asymmetric. Benign lesions have even borders, and malignant lesions have uneven borders. Benign lesions have an even color throughout the entire lesion. Even borders, even color. Malignant lesions they could be darker in one part, lighter in another part, really dark in one part. And benign lesions simply don't grow, whereas a malignant lesion, the diameter increases over time. This is a perfect example of a benign lesion. It's got an even color, even borders, and it's quite symmetrical. The diagnostic test for melanoma is a full thickness biopsy. This is absolutely indispensable. Do not shave that lesion because it has a huge implication for whether you need prophylactic radiation, chemotherapy, and simply prognosis. The treatment is surgical removal, and you've got to include normal skin surrounding the lesion. Now, because it's a step 2 exam, no one expects you to know exactly how much. The bigger the lesion, the greater the size of the border of normal skin. Interferon injection is helpful in widespread disease. That's because melanoma is an immunologically active lesion, and therefore a lesion which would otherwise be considered to be cancer, here in this case can get an immunologically active manipulation like interferon. Melanoma has a strong tendency to metastasize to the brain, and although melanoma is about only 1 to 2% of all cancer deaths in the United States, it's the number 4 lesion to go into the brain. Squamous cell cancer is straight on ahead sunlight, and this is the most frequently tested thing. There's an enormously greater incidence in organ transplantation. It is not so much the organ transplant, but the immunosuppressive drugs. Now, it might be a little artificial to break that up as to whether it's a transplant or immunosuppressive drugs. But if you were asked, and I have seen questions like this, immunosuppressive drugs is the correct answer. You see, we have cancer cells arising in us all the time, and there's immune surveillance. The immune system is like police, really. They're to pick up criminals, and the cancer cells are like the criminals. And basically, immunosuppressive drugs make the surveillance of those small individual cancer cells ineffective, and they are allowed to grow, just like a criminal in the system. Squamous cell starts looking like an ulcer. It just doesn't heal, it keeps growing. You have to biopsy and remove. Squamous cell starts out as an ulcer, but you also notice that it's on a very sun-exposed area, and the baseline color of the patient's skin is extremely pale. It'll also describe people who are outdoors a lot, people who work on roofs, people who are house painters, people who work outside, people who spend a lot of time on boats outside, Australians. None of these skin lesions are as common as this cause of skin cancer as basal cell carcinoma. Well, that's the good news, actually, because it's very benign compared to the others and takes a very, very long time to go anywhere. The question is going to describe something as waxy. Now, that waxy is because it's not ulcerated and not hyperpigmented. It'll be shiny like a pearl for the same reason. Unlike melanoma, wide margins are not necessary because the metastatic potential into local skin or elsewhere into lymph nodes is extremely small. A shaved biopsy is fine in this case. It's diagnostic because since it's so rarely metastasized and since there is no chemotherapy, we don't have the same considerations of chemotherapy and knowing whether it's going to go metastatically into the local lymph nodes. The recurrence rate is much less than 5%, and basal cell use Mohs microsurgery, a very interesting thing, mostly to prevent deformity. Is a basal cell carcinoma? Well, if you look at it, you wouldn't really know now, would you? You wouldn't know until you'd taken a biopsy, and that's the whole point. A pale gentleman, sun-exposed areas, not hyperpigmented, waxy, and shiny like a pearl. Mohs microsurgery is basically a dissecting microscope. You remove the skin cancer under a dissecting microscope, but the most important thing is look at the lesions. It was on the person's nose. This is very thin slices of skin removed. Basically, when you have a lesion that's on a face in a sun-exposed area there, an extra couple of millimeters makes a huge difference in terms of the cosmetic appearance. You do an immediate frozen section as you make thin little slices because you will cut just to the point where you know you've removed the cancer, and you'll stop cutting as soon as you hit normal tissue. So this is an extremely precise way to treat skin cancer. Mohs will remove the cancer and keep the normal skin intact. And that's because you can stop resecting when the margin is cancer-free. There's no need to remove wide margins, and Mohs is best in the delicate areas around the eyelid and around the ear. The ear is especially problematic. We just don't have a good way to grow cartilage. If you have to remove something around the ear, you can't fold the cartilage, you can't pull it, there's no stretch in cartilage, and there's virtually no vascular supply to it, so it's a very difficult area to manipulate. Kaposi sarcoma, or KS, is very interesting because in the past, KS was seen only in older men of Mediterranean origin. It was felt to be a very slow, non-pathologic, non-pathogenic, not growing very fast lesion in the legs of old guys who hung out on the beach in Sicily for 25 years. And then all of a sudden it shows up in AIDS in the 1980s. And we know then it took a long time, but to find out that it was from human herpes virus 8, HHV8, which is an oncogenic virus. And that's one of the characteristics of HIV. HIV unlocks the Epstein-Barr virus, then you get lymphoma. It unlocks the papillomavirus, then you get cervical cancer or anal cancer. It unlocks oncogenic viruses to give more cancer. And that's why lymphoma and cervical dysplasia are AIDS-defining diagnoses. Now, it's reddish-purplish, which we'll show in a second. It's more vascular than the others. That's why it is reddish-purplish. And generally speaking, we don't biopsy it because it's more vascular and tends to bleed. So what's different about Kaposi's sarcoma is that we diagnose it by how it looks. This is true both on the skin and when we see it in structures such as the bronchial tree or when it's in the gastrointestinal tract. And the reason we don't biopsy it is because it bleeds. And bleeding in the bronchial tree is especially problematic because it obviously is like drowning in a little way. So Kaposi's sarcoma will be these reddish-purplish lesions in a person with HIV, and that's all you have to do as a diagnosis. Because it's also in the GI tract of the lung, it's also in HIV via sexual contact that's associated with Kaposi's sarcoma. And when it's in the GI tract, you see it on endoscopy, and it's its visual appearance. It looks just like it does on the skin, but inside your lung and inside your guts. Injection drug use AIDS is rarely associated with Kaposi's sarcoma. Now, we knew for the first 15 years of the HIV epidemic that it followed the epidemiologic patterns of a sexually transmitted disease. But it wasn't until little bits of genetic elements of human herpes virus 8 were identified by PCR technology that it finally took 15 years of straight experimentation to be able to finally say, it's an STD. Unlike other skin cancers, KS is not routinely removed surgically. You treat the AIDS with antiretrovirals, and the majority will disappear as the CD4 improves. It is so dramatic that you rarely need intralesional injections of vincristine or interferon, and few people fail to resolve by raising the T-cell count. We use chemotherapy with liposomal doxorubicin. When you want to protect people from the adverse effects of chemotherapy, you encase it in a liposome, and this basically simply reduces the toxicity. You can be covered from head to toe with KS lesions and have zero T cells, give up your kids for adoption, be DNR in a nursing home weighing 75 pounds, go on antiretrovirals, and within 2 weeks to 6 weeks, you will get up, tear up your DNR, take your kids back, and walk out of the nursing home. Actinic keratosis is premalignant. It's like cervical dysplasia. It's from high-intensity sun exposure in fair-skinned people, and there's a very small risk of squamous cell cancer in each individual lesion. But if you can consider that people might have 100 of these lesions, even though it might have only a 2 or 3% chance per lesion, it means that if you have hundreds of them, you're going to get squamous cell over time. Actinic is a sun ray. The word keratosis doesn't mean anything bad. I mean, seborrheic keratosis goes on to nothing. That's basically just the skin lesion's benign liver spot. So it's not the word keratosis that's bad. It's the actinic part that's bad. Well, this you would not pick up as an actinic keratosis unless you biopsied, and that's the whole point. Fair-skinned person, sun-exposed area, and you'd have to take a little sample of it, in much the same way that you'd have to do a pap smear. You couldn't tell by looking at the cervix it was premalignant or had dysplasia. You'd have to take a scraping. Here's a close-up of the same lesion, same principle. Scrape it, biopsy it, take a sample to see if it's premalignant, and if it is, remove it. Finally, remember that many of these occur in a single person. The risk is cumulative. The more you got, the more risk you have. And like cervical dysplasia and cervical cancer, it is slow to progress. And you can remove them with curettage, cryotherapy, or liquid nitrogen, laser, topical 5-FU, or imiquimod. Imiquimod is a local immunostimulant that basically tells your T cells that the cells on the surface are foreign. It makes your own T cells slough them off. This is the same treatment as you could use for a person with molluscum contagiosum or venereal warts, condyloma acuminatum. It is self-administered, it never burns, and doesn't go too far. It's like vitamins for T cells. Seborrheic keratosis, the very word seborrheic means benign. It's very common in the elderly. They're hyperpigmented lesions. They can be called liver spots. They just appear stuck on, and they look like melanoma, but the key issue is they're not melanoma. They have zero malignant potential, and they are here so that you don't biopsy them. Don't remove them unless it's for cosmetic reasons. Now, when you do want to remove them, you remove them by using the same sorts of cryotherapy with liquid nitrogen and the same sorts of surgery and laser, and only for cosmetic reasons. You just don't like the way they look, but you don't have to remove them because they're going to go on to cancer or metastasize. They never go on to cancer or metastasize. But here they can look bad, can't they? Well, if this was melanoma, this person would be dead a long time ago. If you had melanoma this widespread, that would be metastatic. This would be a picture of a cadaver. Well, this is so common, they start off as tiny and they just grow over time. It depends what people like. You can leave it alone or you can just cover them up. But you don't have to do it because of medical reasons. They never go into the lymph nodes, ever. Atopic dermatitis is incredibly common skin disorder. It's kind of like a seizure disorder of your T cells, and it's associated with overactivity of mast cells in the immune system. And you look for a history of people who have asthma and allergic rhinitis and a family history of atopic disorders. In other words, allergies are associated with this. Allergies in families and allergies in skin. And it's very rare to start over the age of 30. It starts in kids, very uncomfortable for them. In the same way, it would be very rare for somebody to start being asthmatic when they're 50. It's a seizure of those mast cells. In the same way, we don't call it atopic dermatitis if you eat chocolate and you're allergic to chocolate and you release some of the mast cells and you have histamine. This is from unprovoked release of histamine. Premature and idiosyncratic release of transmitters like histamine, and that means it's not from an allergic reaction. Now you itch like it's an allergic reaction. You itch, you scratch, and that scratching leads to scaling rough areas of thickened skin, especially on the face, neck, and skin folds, and behind the back of your knee, and it's uncomfortable. And the problem is the more you itch, the more you scratch, the more you scratch, the more you itch. And that's why this image is just of what happens when somebody scratch, makes the skin thick, scratch, breaks it down, scratch, and you drive staphylococcus under your skin, which makes you itch and scratch some more. This could be elbows, in which case this is, or backs of knees. The skin folds are just where you itch and scratch an awful lot. It's very uncomfortable. Got to cut those fingernails down and make sure you don't use too much hot water or soap or you itch and scratch some more. So when you itch and you're uncomfortable, you scratch. When you scratch, it irritates the skin and the mast cells, which release more histamine and make you have more itching. Then the superficial skin infections from staphylococcus happen as you drive those antigens and drive the bacteria under your skin with your own fingernails. And as the microorganisms are driven under the epidermis by this scratching, this in turn makes more itching, and the skin gets thickened because of the scratching and the drying, and that is termed lichenified. The CH here is pronounced like a K, lichenified. And this is just not a food allergy. It's not. This is not like I'm allergic to peanuts. It's not. It just happens. It's a seizure disorder. If you have a brain tumor and you seize, that's not epilepsy. That's having a brain tumor. The key here is to stay moisturized so your dry skin doesn't remain as itchy. Stay moisturized. Dry skin is more itchy. Use a humidifier, especially in winter, because dry skin is more itchy. Now I feel like I work on the first floor of a department store here where I want to have you buy soaps and cleansers and various lubricants to, and avoid bathing too much. Stay a little dirty. Harsh soaps and anything that irritates your skin, makes you itch and scratch some more, like brushes or washcloths, hot water, anything that rubs on the skin. And cotton is less irritating than wool. Wool is simply much more irritating to all skin. Yeah, you had to go to medical school to learn that, right? Don't wear wool. It makes your skin irritated. IgE levels are elevated in atopic dermatitis, but we're not doing that as a clinical test. Here we go. Back to the doctor part. Topical corticosteroids are used in flares of disease, and we really try and avoid oral steroids. Oral steroids are only in the most severe acute flares. Now, tacrolimus and pimecrolimus, sirolimus, these medications are T-cell inhibitors. They're useful in organ transplant patients, in bone marrow transplant patients, longer-term control, and we can use them topically to help stop the need for steroids. And we want to get you off of steroids because steroids cause atrophy. They cause atrophy of skin. And they're used systemically in the organ transplant patients for the same reason, to get them off of steroids and to prevent the organ rejection, but topically for atopic dermatitis. The antihistamines of atopic dermatitis are newer non-sedating medications like cetirizine, fexofenadine, loratadine, which some of you may know as Zyrtec, Allegra, and Claritin. They're all the same. They're identical. Anyone who says something different is selling something. Severe disease is hydroxydine and diphenhydramine and doxepin because those drugs are far more sedating. Remember, diphenhydramine is so sedating. It's sold as a sleeping aid. But if you have very severe disease, you might have to use it. Antibiotics, orally we have cephalexin, known as Keflex, mupirocin, vertepamulin. That is something that be new for people, and that's basically an improved version of bacitracin. And these medications are used when impetigo occurs to try and stop you from itching and scratching. Ultraviolet light, which is phototherapy, also works for recalcitrant disease, the same as it would for psoriasis. Psoriasis is an incredibly common disorder. 2 million people in the United States. Wow. Silvery, scaly plaques. Not itching most of the time because it's a superficial. It's on top of where you'd have the immune system. It's in the epidermis more. It's actually not as much a lymphocytic release of histamine problem like atopic dermatitis is. Psoriatic arthritis with nail pitting is only in about 10% of patients. And you can have psoriatic arthritis with only a small amount of psoriasis. It's not like you get a ton of psoriasis and then you get the arthritis. You can have the psoriatic arthritis with a small amount of it. And extensive disease, though, is associated with depression just because people's life is miserable. Who wants to walk around with that stuff? Psoriasis has extensive silvery scales. When you have someone with lesions as widespread as this, you can't cover them with topicals. This is a person who needs ultraviolet light, or tumor necrosis factor inhibitor, TNF inhibitor, or methotrexate rarely. But this is too extensive for a person to use just topicals. Psoriasis treatment is by far the most complicated of all treatments in all of dermatology because you have to start out with a lot of steps. Localized disease is treated with topicals. Psoriatic disease is never treated with oral steroids. It's just not. Topical high-potency steroids like fluocinolone, triamcinolone, betamethasone, clobetasol. But like steroids anywhere, they become complicated from adverse effects. They atrophy the skin. They take skin and they melt it, and they turn the amino acids of collagen into sugar. So to get you off of steroids, we use vitamin A and vitamin D ointments to help get the patients off of steroids. The vitamin D agent is calcipotriene, like vitamin D3, tri-3-ene, calcipotriene, and steroids cause skin atrophy. Coal tars are a very difficult thing to take because how do they look? Really covering yourself in oil is not too pleasant. Pimecrolimus and tacrolimus are not as strong, but they can be used in delicate areas of the face and the penis. They're an alternative to steroids, and they're certainly less deforming than steroids and less messy than a coal tar. Steroids cause atrophy. They stop collagen growth and formation and convert it through gluconeogenesis, convert the amino acids into glucose. You can't use topical steroids forever. It'll harm the skin. You can't use topicals for disease spread up and down and all around the body. Ultraviolet light, you can select out the version of it that controls disease without the version that causes skin cancer. However, TNF inhibitors are what you're going to use if the UV light doesn't control your disease. Etanercept, adalimumab, infliximab. Yes, these drugs actually are pronounced that way and spelled that way. Yes, they're correct. And yes, you got to learn them. They are a miracle. They shut it down, and they're not as toxic as methotrexate. Methotrexate is after those. You'd only use methotrexate if the TNF inhibitors failed, because methotrexate causes liver and lung fibrosis. Liver and lung fibrosis for methotrexate. But you'd have to use them on psoriatic arthritis, the methotrexate for psoriatic arthritis, because you can't use light for joint involvement. Well, here's a nice frequent question that you'll be asked and you'll know. TNF inhibitors, adalimumab, infliximab, etanercept, can reactivate tuberculosis. You screen with a PPD, no big deal. Your PPD is positive, just take the INH and start your drug. Pityriasis rosea is problematic only in the sense that it looks like syphilis. It's an idiopathic transient dermatitis. It starts with a single lesion, a herald patch, then disseminates out through the rest of the body. It looks like secondary syphilis, but definitely spares the palms and the soles. It's transient, and some people, because it itches a lot, you can use steroids or UV light. The biggest issue with pityriasis rosea FU is unquestionably the diagnosis. Looks like secondary syphilis, excludes secondary syphilis because it's not on the palms and soles, and the VDRL and RPR is negative. Now, pityriasis rosea, here's a picture of it. Woo, look at this. Disseminates around, flat, reddish-brown lesions. And the good news is that it doesn't go anywhere, it doesn't do anything. It will always resolve. Seborrheic dermatitis is a hypersensitivity reaction to a fungus in the skin. It is a dermatophyte that causes a kind of a over-secretion of sebum. Makes the lesions look oily and greasy. It's dandruff. And because it's a hypersensitivity to a fungus, that's why you can use both antifungals and steroids. That's why you can use both topical steroids and antifungal agents like ketoconazole are useful. And this is one of the only places you do use ketoconazole, because we don't use ketoconazole systemically too much because it causes liver toxicity, because ketoconazole is profoundly anti-androgenic. Seborrheic dermatitis occurs more frequently in HIV and Parkinson's disease and in the elderly, and the very word seborrheic, which means flow of sebum, equals benign. Pemphigus vulgaris is a type of idiopathic autoimmune, and there is a form that's drug-induced. And it can be associated with ACE inhibitors and penicillamine, phenobarbital, penicillin. Well, in many of the same ways, that's what causes allergic interstitial nephritis. Penicillin, sulfa drugs, allopurinol, phenytoin, and you make an allergic reaction against your skin. Well, you might say, well, isn't this very similar to the types of drugs that might also cause Stevens-Johnson? Yes, but the reaction is markedly different. Pemphigus vulgaris is from autoantibodies that split the epidermis. Now, this may sound like no big thing to you, but this is exactly why it is that Pemphigus vulgaris is so dangerous. Splitting a very thin structure like epidermis results in bullae that easily rupture. They're just too thin. They're thin-walled, and they involve the mouth. And because they involve the mouth, and because they're thin-walled, and because they break off, you lose a lot of fluids and you get infected. And that's why, widespread, they act like a burn. And that's why untreated, Pemphigus vulgaris has a 40 to 60% mortality. Wow. Here's a picture of this in the mouth. And remember, bullous pemphigoid does not go into the mouth. It's a photomicrograph of the splitting of the epidermis. That's why that big open thing on the top that looks like a dome is the splitting of the epidermis. See how tiny that is? See how thin, how fragile? Of course it breaks off, and you get infection and fluid loss. Nikolsky sign means that you can remove skin, which is the finger's worth of pressure. That's the characteristic finding of Pemphigus vulgaris, or any disease in which there's such tremendous loss of skin that just touching the skin pulls the skin off and you denude the skin from mild pressure. This Nikolsky sign is something that means that the person could die without treatment,
because it's removal of superficial layers of the skin in a whole sheet while pulling on it with just a tiny bit finger's worth of pressure. Well, welcome to dermatology, the most accurate test of biopsy for almost everything. And so it is with the blistering disease as well. The biopsy will show autoantibodies on immunofluorescence studies that show the splitting of the epidermis. And without treatment, pemphigus is incredibly fatal. You die of an infection. Steroids are life-saving. Systemic steroids, like prednisone, are life-saving. Azathioprine and mycophenolate are used to keep people off of steroids, as they also are in many immune diseases, such as glomerulonephritis or lupus nephritis. Rituximab, which is a monoclonal antibody against CD20 cells, removes the lymphocytes that make autoantibodies. They're anti-CD20 cells, so they're anti the cells that make the antibodies, or intravenous immunoglobulin in refractory cases that just don't get better. Bullous pemphigoid is like pemphigus. That's what the word means. Like pemphigus, pemphigoid. Like the difference between erysipelas and erysipeloid, or leukemia or leukemoid reaction. Similar to. It's similar to pemphigus in that it's a bullous disease, but the bulli stay intact, and they stay intact because they're thicker, and there's less loss of fluid, less infection, and less mouth involvement, and all this related to the top thing, which is the bulli stay intact. You can't get infected if you're covered with skin. The best covering for skin is skin. And here's a picture of intact bulli. Bullous pemphigoid, biopsy, steroids.
In bullous pemphigoid, biopsy with immunofluorescence stains is definitely the most accurate test. The best initial therapy is prednisone, and to get patients off of steroids, because in the long term, even after a few weeks, steroids can be very deforming, have many adverse effects. We have to use azathioprine, cyclophosphamide, or mycophenolate to get them off of steroids. Mild bullous pemphigoid responds to erythromycin, dapsone, strangely nicotinamide, not niacin. Remember, Nikolsky sign is absent in bullous pemphigoid. The lesions stay intact. Nikolsky sign specifically implies a lesion that is so large and so extensive that only the slightest pressure will completely denude the skin.
Other blistering skin disease, such as porphyria cutanea tarda, happens because sun-exposed areas release an abnormal reaction to porphyrins. This is an abnormal porphyrin metabolism problem. So in sun-exposed areas, the sun hits those porphyrins, causes a very bad blistering skin disease. Now, it's more common in people with a history of liver disease and cirrhosis and hepatitis C, alcoholic destruction of liver. Well, now we're just listing things that cause liver damage. Ooh, but this is unique. Estrogen use. Why? I don't know. It's an idiopathic disorder. Iron overload, for sure. Hemochromatosis and iron overload are associated with porphyria cutanea tarda. The most frequently asked of these associations is hepatitis C. It's not that the others don't do it, it's just hepatitis C is the most frequently asked. Hepatitis C is just a favorite question for porphyria cutanea tarda. They could be asking about the other ones, but it's just popular because you can fix and eradicate the hepatitis C with interferon, ribavirin, and either boceprevir or telaprevir, so you can eradicate it, you can treat it. Look for involvement in the back of the hands and face, simply because those are the most sun-exposed areas in the body. The most accurate test for porphyria cutanea tarda is uroporphyrins on the 24-hour urine. After all, it's a problem with porphyrin metabolism, and they go into the urine. So a deficiency of uroporphyrin decarboxylase activity is what causes this. So the porphyrins just build up in the urine. The treatment is based on stopping the estrogen, stopping the alcohol, stop the cause, stop the estrogens, and remove iron with phlebotomy, and certainly treat the hepatitis C.